Good afternoon, everybody online. If you could just give us a few minutes, we're just going to set up and then we'll get started. I'm just going to turn my camera off until we're ready.
Hi, Rebecca. I've made you the spotlight so everyone will be able to see hi, your screen. So it's showing correctly. I just can't hear you. That's the only thing. So if you just unmute, then you're good to go.
Can you hear us, Alec?
Yeah, perfect. That's good. And then if you just share your screen, Rebecca, it will be able to, on your profile, on your presentation.
How's that?
Done. Perfect.
Oh, good. Okay. Excellent.
Thank you, everybody, for joining online. Pardon?
Hi, it's Dr. Khan here, the GP. Can you talk?
Yes.
Were you in hospital recently?
And
did they make some changes to your medication?
Let me mute him. Yes. We admire the multitasking, though.
Hello, everybody online. Thank you for joining us. I'd like to introduce you to Dr. Rebecca Schofield, our consultant cardiologist, and I'll hand you over.
Wonderful. Thank you. Well, wonderful to see so many people in person and so many of you online. So my name is Rebecca Schofield. I would call myself a general cardiologist, really, and I've done quite a lot of general medicine in my career. my sort of subspecialty interests are cardiac imaging, which again I think keeps me quite general. So I was going to just use this bit of time just to talk about palpitations, because I think it's a symptom that we see quite a lot, and there is a kind of I suppose a threshold in which people are referred to secondary care or referred for onward investigation, but that can be quite variable between practices and between different healthcare practitioners. So this is just sort of an approach that I've gravitated to, but it's by no means to be, you know, sort of it's an approach which you can take or not take as you wish. It's not it's certainly not anything more than that. So over the next probably half an hour or so, to allow us plenty of time for questions, what I was going to cover is why palpitations matter, and then a little bit about an approach to assessment using a sort of red, amber, green tool, and then some of the sort of tests that we will do in secondary care, and really why history examination and 12-lead ECG is still so important and mustn't be forgotten about or overlooked. So palpitations matter because they're a very common presentation, both in primary care, but to emergency departments and certainly to general cardiology departments, you know, worldwide. They often cause a huge amount of anxiety for the patient who's suffering from the symptom, and they can often be quite difficult to capture because of our difficulties in ambulatory rhythm monitoring, which we'll touch on a bit more in detail later on. And the difficulty we have is being able to differentiate those very low risk palpitations that need reassurance and to be informed that their palpitations have no significant underlying cardiac cause. But within that group will be the occasional life-threatening arrhythmia. And so this is where the anxiety both from the patient and the healthcare practitioner comes from, because occasionally they can be the harbinger of a then aborted sudden cardiac death, or exactly like I've said, a life-threatening arrhythmia. And the key thing about palpitations, I think, is to remember that it's a symptom reported to you, but the onus then is for us to make a most likely diagnosis. Very difficult sometimes in medicine to be absolutely certain about anything, but we have to make a most likely diagnosis. So the core principles of assessment, I think, are to identify any of these red flags, and it's these red flags that really will make you think, well, this could be one of those high risk not to miss. The history will often tell you the likely etiology. So patients will often report, their heart's beating normally, and then suddenly a big forceful beat that feels as if it's going to come up out of their throat or burst out of their chest, and then a pause as if their heart's going to completely stop beating, and then they go back into normal rhythm. And that generally is an ectopic beat that the patient is experiencing, and it feels different because the myocardium is being activated in a different way. But that sort of history is often quite key, but you can imagine how unpleasant that symptom is to feel. As we said, some of the difficulty is capturing the rhythm disturbance during symptoms. So, we can hire monitors, you can loan out monitors to patients, but generally they're 24, 48, 72, 7-day monitors, as you well know. And the patient will not get their symptoms to order. And it can often be very frustrating on both sides that the patient gets their symptoms the minute they've handed their monitor back. So going back home on the bus, or the minute they've given it back, suddenly they've got loads of symptoms again. There are some devices now which are sort of able to capture more sustained palpitations, like things like the AliveCore. But again, that requires the coordination of getting it out of your pocket or your bag or your glove box or your office drawer, activating your app on your phone, holding the device. And so often symptoms have dissipated, they've resolved before a rhythm capture can be made. We find a lot more patients now using wearable technology, and there's variability within those as to whether or not they can show you a heart rate histogram, or whether they can make a single lead ECG recording. And sometimes that can be very helpful, and sometimes it can not be that helpful because of interference and artifacts and things. But there's certainly a lot more options for patient wearable rhythm monitoring than we had, say, 10, 15 years ago. And then we're sort of assimilating all that data to try and risk stratify the patient and then guide who then would be ideal for onward referral for secondary care further assessment. So as I said, the history taking is often, I think, the most important tool, and spending time talking to the patient about the palpitations can be really helpful. And sort of pushing through those initial difficulties sometimes with history taking, where you ask a question and you get a completely, you get the answer to a completely different question, but being sort of persistent in, that detail, that granularity of detail. Is the onset sudden, or is it gradual? Are the symptoms lasting seconds, minutes, hours? How frequent are they? Are they every day, every month, 3 times a month, twice a year? And it can be difficult for patients to recollect, particularly in the pressure of being questioned, being interviewed. But often if you sort of just give them a few more cues, did you have them before Christmas? Have you had them since Christmas? Did you have them before you last went on holiday? Some just gentle cues can often help them remember, oh, actually, I've probably actually had, say, 3 in the last 6 months. And then the description of what they're feeling. So, do they feel a sudden onset, very regular heart rhythm that makes them feel very giddy, very breathless, short of breath, chest tightness? They need to sit down. They often feel as if they might pass out. Suddenly it goes very quickly again. So those sorts of symptoms can be much more likely to represent a more sustained palpitation, like a supraventricular tachycardia or atrial fibrillation. And I do still think that asking the patient just to tap out the rhythm, or go through it with them, is it very regular, does it feel irregular all over the place, can help. Triggers are also quite interesting to go through with patients. So if they always get symptoms whilst exercising, that's quite concerning. Most palpitations that are benign will get better with exercise. But also other triggers that can also help the patient to understand that maybe their palpitations aren't actually heart related, they're related to something else. And things that they may not have twigged can cause palpitations, like drinking 8 cans of Red Bull a day, or I've also had using an ice bath 15 times a day, quite extreme forms of lifestyle that they may not have understood could be contributing to their symptoms. And also anxiety, stress, sleep quality, processed foods, high sugar diet, all of those things. And so, as we said, the ectopic beat often feels like a very forceful beat. And they'll sort of describe it quite sort of dramatically, like the heart jumping or pounding or butterflies, or and they can have several in an hour, or they might go on for several hours. So to me, if their symptoms are lasting several hours with no other associated features of breathlessness, dizziness, chest tightness, then they're more likely to be experiencing intermittent ectopic beats. The SVT history is often quite, it is very different. So this sort of sudden onset and very fast palpitations, they have to sit down, they're feeling as if they'll pass out. If they check their pulse, it's well over 160, often up to 200 beats per minute. And they may have over the years come up with self-regulating tools. So they might hold the breath, or sort of bear down, or dump their face in cold water, or do a headstand. Or over the years, they might have come up with various different sort of ways to self-regulate that can be quite imaginative. And AF again can be difficult, and I suppose it's all about the clinical context. So for me, patients with the associated comorbidities of obstructive sleep apnea, hypertension, diabetes, previous coronary disease, patients over the age of anything really over 65, but certainly over 80, I feel duty bound to rule out AF, really, because AF is so much more common in those patient groups, and the management in terms of anticoagulation and stroke prevention is so profound in terms of their quality and quantity of life that I think I almost feel duty bound to rule it out. The key things in the past medical history is there any history of structural heart disease? So has the patient got a history of cardiomyopathy? Have they had previous myocardial infarction or coronary interventions or bypass surgery? That makes the likelihood of scar within the myocardium much higher, the likelihood of induced left ventricular systolic function so much higher. That then increases the clinical probability of a ventricular arrhythmia and a more likely life-threatening form of palpitation than patients without any form of structural heart disease or previous MI or coronary intervention, bypass, etc. Other key things not to miss are obviously thyroid disease, or patients that you have got concomitant tachycardia and hypertension who are young, you might start thinking, is this actually symptoms and signs of a pheochromocytoma, etc. So things to think about in the past medical history. In terms of family history, the key questions I'll always ask is, is there any family history of sudden cardiac death? Or patients very rarely understand it in that terminology, but usually, has anybody in the family died before the age of 40 in unexplained or unusual circumstances? Is there any family history of heart muscle disorder? Has anybody had a cardiac pacemaker or cardiac device? Or has anybody in the family been told that they've got a problem with their heart electrics? Again, if they had a defibrillator, has anybody had genetic testing? Are they under regular follow-up with any ongoing cardiology services? And it's difficult now because families are often fractured. They may not talk to each other about their health conditions. They may be living in different parts of the world. So, that might be something that you sort of have to come back to at a second consultation. Medications and substances that can increase the feeling of the heart beating or palpitation are things like beta agonists and decongestants. And I think it's also important to think about the use of recreational drugs. So in terms of then an examination, things looking out for are their resting heart rate, blood pressure, including if there's a postural drop, their oxygen saturations, are there any obvious signs of thyrotoxicosis? Have they got a goiter? Are they tremulous? Have they got thyroid eye signs? We do, particularly in cardiology, when we're more sort of single organ doctors, we're trying to push everything that we get through a cardiology prism. So actually, we do end up often late on in the day diagnosing thyrotoxicosis in after patients being around the usual battery of cardiology tests, and suddenly we've thought about different things. So I think, more generalists are far more likely to think in the round about the patient's symptoms. You might find that the patient's in AF at the time that you examine them, which again makes life a lot easier in some ways in terms of diagnosis. So clinical examination is always valuable. Auscultation for cardiac murmurs is also helpful because it gives you an indication that there's likely to be underlying structural heart disease, and you will want an echocardiogram in those patients that you hear an audible murmur. And are there any signs of associated heart failure? Again, that's making you think, is there some underlying left ventricular dysfunction? Has there been a large myocardial infarction and impaired LV function, etc.? So yeah, the exam might give you the diagnosis if the patient is in their arrhythmia at the time, but it's unlikely to. But you do get that contextual sense of overall risk and thinking about other influencing factors from the examination. So in terms of risk stratification, any sort of palpitations associated with syncope or collapse, associated with severe central crushing chest pain or breathlessness, because I think if you just say, do you get any chest pain when you get your palpitations, most people will just say, yeah. So I think you're getting that history of, is it severe central tight pressure? Do you have to stop? Does it make you feel sick? Does it go anywhere into your jaw or your shoulder? Do you get sweaty? It's that kind of presentation rather than just somebody who gets a bit of stabbing chest pain at the time they get the palpitations. It's a real red flag. Anybody with family history of sudden cardiac death, so sudden death in anybody less than 40, or known structural heart disease, maybe they've had multiple MIs, bypass grafting, they've not been seen by cardiology for 20 odd years, and they're now coming to you with palpitations and syncope. That's someone that you want to urgently refer, because the likelihood of them having an ejection fraction of less than 30%, left bundle branch block and sustained VT is very, very high. You might want to send some of those patients directly to ED for that same reason. But they don't come along very often, but they're not to miss. That's the key thing. The patients that are more, come on, sit down, yes, welcome. That probably do need to see a cardiologist are those with the exercise-induced palpitations, because as I said, most palpitations that are benign will get better with exercise, and actually exercise is one thing I strongly recommend to most of my patients who I see with benign palpitations, because actually the more physically fit they are, the more they can test their heart and get their heart rate up to 85% of their maximum age predicted heart rate, and sort of keep it there, the fitter they'll feel and the less they will experience their palpitations. So exercise-induced palpitations is a warning sign that these symptoms may not be benign. So patients with an abnormal ECG, and the things that sort of I would say constitute an abnormal ECG are things like left ventricular hypertrophy, T-wave inversions, evidence of pathological Q waves. So not necessarily, an isolated finding of left axis deviation or an isolated finding of first degree AV block. Patients who are getting quite frequent and sustained tachycardia, again, it's helpful to see those patients because we're much more likely to be able to demonstrate the cause with ambulatory monitoring. And anybody that does have a history of structural heart disease, so there might be patients that have got valvular heart disease or have had valvular intervention or have had MIs or coronary artery bypass grafting or stents. And then this low risk group, the group that really predominantly can be sort of reassured and managed within a primary care setting in the first instance, because obviously we all understand that for some patients, reassurance and lifestyle doesn't cure their condition, and their anxiety might mean that they just can't manage their condition, and they may require ongoing referral for further investigations and a more comprehensive reassurance. But in the first instance, this low risk should ideally be managed with lifestyle modifications and reassurance in primary care settings. And they're those patients with none of the red or amber flags that are otherwise sort of fit and well with a normal ECG, and their history is very suggestive of ectopics or just awareness of sinus tachycardia. So in terms of first line investigations, always helpful just to make sure they're not severely anemic, or they haven't sort of got very deranged electrolytes, and that they haven't got thyroid dysfunction. In the bigger clinical context, it might be helpful to think about their overall cardiovascular risk. Have they had an up-to-date HbA1c? Have we checked their fasting lipids? And if patients on a lot of diuretic therapy or has intestinal absorption issues, high output stoma, or any of these sorts of things, additional electrolytes might be helpful just to make sure that they're not abnormal. And then the ECG findings to cause concern are left bundle branch block, evidence of Q waves, which is suggestive of a previous myocardial infarction. If you see obvious pre-excitation, so that's our very short PR interval with slurred upstroke, and that's quite obvious, and a lot of the computer-generated reports will be clued into highlighting that as an abnormality. Again, same thing with long QT, complete heart block, patients with voltage criteria for left ventricular hypertrophy, and often then with reciprocal T-wave inversion, because that's much more it's much more likely to have true left ventricular hypertrophy if you get those reciprocal T-wave changes. And I've just put in bifid P waves because, again, it's the sort of ECG marker of left atrial dilatation that just increases your potential risk of developing atrial fibrillation if you have a dilated left atrium. So the use of echo. So over the years in different guises, I've done quite a lot of work on the use of echo in assessment of say, unselected patients presenting with palpitations. And by far and away, the vast majority will have a normal echo. Now, that's not to say it's not clinically relevant because or clinically useful, because actually, if you can say to a patient, and I often do, in this context of a completely structurally normal heart, the likelihood of these palpitations is as awful as they might feel, causing you any severe harm or untoward features, damage, etc., is incredibly low. So that reassurance of knowing, particularly if there's been a family history or they've recently watched a football match where there's a player's dropped down dead, or there's all sorts of things that may be at play, in their own mind that's driving the concern. But just be mindful that the vast majority of these unselected patients will have a completely normal echo. Now, those with the amber and red flags, much more likely to have a structural abnormality. But the vast majority of people that we do see with palpitations are in that green zone. They don't have any history or concern for structural heart disease. Things, if you do an echo in primary care and want to get the results of that before onward referral, the things not to ignore and be concerned about are a dilated left ventricle with evidence of regional wall motion abnormalities, because that tells you that the patient has had a large territory myocardial infarction and their risk of ventricular arrhythmia is so much higher. A dilated ventricle with global hypokinesis, so what they may put in the headline of the report, suggestive of a dilated cardiomyopathy. Again, the risk of ventricular arrhythmia here is so much higher. Any features that might suggest hypertrophic cardiomyopathy, and again, most cardiac physiologists now are very good at sort of putting the results into the context rather than sort of listing abnormalities that, unless you're in the know, are all suggestive of hypertrophic cardiomyopathy. They'll usually report, this echo shows features of hypertrophic cardiomyopathy, including, systolic anterior motion of the mitral valve, left ventricular outflow tract obstruction. They'll usually couch it in that way so that you don't have to know all the esoteric features to know that that's what they're getting at. Very high probability of pulmonary hypertension is also another concern, because those patients have a sort of fixed cardiac output and they can get syncope, and syncope in the context of pulmonary hypertension confers a very poor prognosis. And again, I put in severely dilated left atrium, because if I see that, then I think, well, if the patient's not got AF now, they're going to within the next few months, years. A sort of atrial septal defect, because we do occasionally see people in their 70s, 80s, 90s with undiagnosed congenital heart disease, and it's usually an ASD. And these patients are much more at risk of atrial arrhythmias. So again, it just increases your likelihood of finding AF or atrial flutter. And then which type of monitor should you use? So again, the use of just a sort of blind 24-hour tape without thinking about how frequent are the symptoms, the diagnostic utility is less than 5%. Less than 5% of patients will find, look, you put a tape on, will have any form of clinically relevant finding. So we do a lot of testing for palpitations, which doesn't yield clinically relevant results. But when you are choosing the monitor, you've got to remember what the patient's told you in terms of their frequency. So if they tell you that their frequency is usually every 3 months, then putting on 24-hour tape is nigh on useless, really. You can we can use event recorders. There are devices now which patients can buy from various online outlets, which using sort of AI technology, they can wear a wearable device. They can, at the end of the day, download an AI-generated report, which looks just like a 24-hour tape report. And they can get those devices for about £100. They can have the Alive Core, they can have the Apple Watch, they can have all these different wearable solutions. But there is obviously a concern there about inequality of access. But this issue of sort of matching monitor to symptom is always difficult because, as you said, patients don't get their symptoms to order. But getting an ECG correlation with symptoms is absolutely brilliant in terms of being able to say to the patient, this is what you get. And if you have got patients who are having ectopics, and you can give them a device. So we use here something a bit like, what's it called? It's a bit like what I would say is what I've used previously is like a Zeo patch. So the patient can make can press a button and trigger an event. So then the reporting physiologist can say, on the times of 15 trigger events, on each occasion we saw sinus bradycardia, sinus tachycardia, sinus rhythm, or on each occasion we saw single ventricular ectopic. If you can then show to the patient, when you get your symptoms, when you trigger this device, and this is what you get, it's an ectopic beat. We all get them, they're normal in the general population. We've done your echo, or we haven't done your echo because we've got no concerns to think that your heart's structurally abnormal. It really is powerful. Very rarely for palpitations will we put in a loop recorder. It's very rare. And again, the diagnostic yield is poor. Much more helpful if the patient is having syncope associated with their palpitations. So the common diagnoses, so the vast majority will be ectopic beats. I don't ever get concerned about an ectopic beat burden of less than 10% in a structurally normal heart, and that will be by far and away the most likely group that you'll see. And the other common diagnosis to make is simply sinus tachycardia. The more sort of cardiac causes are atrial fibrillation and SVTs. And again, I would say it's 1 in 20 of the patients that I see will actually have a detectable AF or an SVT. And then a lot of patients will have just a completely non-cardiac cause. So their symptoms actually related to perhaps perimenopause or anxiety or thyrotoxicosis or severe anemia. And yeah, there is no primary underlying cardiac cause. So in terms of management strategy, lifestyle can take a while to go through, and I have to say I will always go through the sort of 4 pillars of lifestyle with patients. So I'll go through their sleep pattern, their exercise, their sort of relaxation and meditation routines, and their diet. And it can take time, but I think it's worth it, because you'll often sort of get to the bottom of why there's symptomatic palpitations, because you'll find out that actually they're only having 2 hours of sleep because they're scrolling on their phone for 22 hours a day. There's often something that's very obvious when you dig down. But always important to sort of go through those things, and always important to consider if they are using recreational drugs, smoking, etc., that really they have to make some good efforts to change those behaviours, and then review symptoms, because often they'll be much better. So what do we do if we find abnormalities? What sort of medications do we use? I don't give beta blocker for benign palpitations. I think that the potential for risk of side effects from medication outweighs any benefits. So as I said to you, for me personally, if the ectopic burden is less than 10%, I reassure them I give nothing. Occasionally I will give beta blocker if their ectopic burden is more than 10%, but again, I would do that with close ongoing review and thinking about what next. Am I going to think about doing more investigations, like, does the patient need an MR to make sure they haven't got myocardial scar? Do they need to have consideration of ablation? Because occasionally electrophysiologists will ablate for very frequent ectopy, because over time, very frequent ectopy, we're talking about sort of 50% ectopic burden, will lead to a reduction in overall LV function. If we find AF, then generally the management will be initially rate control, anticoagulation, and then consideration of whether or not they should go down a rhythm or rate control strategy, depending on the patient context. Quite a lot of electrophysiologists will use flecainide for very frequent intrusive ectopics. Again, it's specialist initiation. We don't tend to use amiodarone because of the long-term side effects, unless someone's got very difficult to control, say, paroxysmal AF, and there's really no other out. And again, you're only using it for a short period. You're not ideally using it for longer than 3 months. And then we do think about catheter ablation for patients with recurrent SVTs that are refractory to pharmacological therapy, or if the sort of lifestyle or occupation means that there's a very low tolerance for having that condition, or in patients with symptomatic AF. And then this is from the, you're familiar with GIRFT, Get It Right First Time, this initiative from a sort of pragmatic orthopaedic surgeon. So they've looked at standardising a national palpitations referral pathway. I think if you look up and down the country, most primary care palpitation referral pathways will look something like this. So it speaks very much to what we've discussed, which is the RAG rating, and then whether managing those low risk patients initially in the community with reassurance. They then also talk again about the basics in terms of history examination and immediate investigations, much of which is what we've already discussed, and what I would say is my clinical practice, and then those cases not to ignore and who should be sent for more urgent assessment. So that's available on, I don't know if you use the NHS Futures website, but I can share these slides if it's helpful. Okay, so the take-home messages are, from me, that most palpitations are benign, but some form of risk assessment is critical. You won't always get it right, we're all human, but to have performed and documented a clear risk assessment is critical. I think that history is by far and away the most valuable diagnostic tool, both in terms of the history of the presenting complaints of the palpitations, but also the history in terms of the clinical context of the patient, because the clinical context tells you what's much more likely to be the case, the reasons we've gone through. The ideal is to capture their symptoms with a period of ambulatory rhythm monitoring, but it's not always possible, or it's not always possible first time. And most patients will get better by having the opportunity to talk through their symptoms with a healthcare practitioner, knowing that they've been through some form of risk assessment process, and then being reassured that their symptoms are benign and will not cause them any undue harm. But yeah, occasionally, as I said, we do find cases that need more than just reassurance, and that's generally initially medical therapy with a beta blocker, rate limiting calcium channel antagonist, or occasionally flecainide, and then the use of ablation if symptoms are refractory to medical therapy. Okay, I think that's everything I had to say. Hopefully I've not bored you to tears.
Could you remind everyone when your clinics are, where your clinics?
Yes, so I'm relatively new here, and I am doing a clinic on a Wednesday morning and a Thursday morning.
And does anybody have any questions for Dr. Schofield online or?
And it doesn't have to be palpitations based, it could be anything you like. And I'll do my best.
Where are you the rest of the time?
So my NHS job is at the Royal Free.
Thursday morning, Thursday morning.
And I have one question. Let's say because we are in the OPD setting and we encountered one of our patient is having a palpitation.
Yes.
And without, like, let's say the setting is already, we have no GP. His consultant is a different specialty.
Mm-hmm.
And like the patient will come to us to approach. Of course, we will check and do the ECG. So what is the proper, like, immediate action taken we can do?
So you mean because you're much more patient facing and patients trust you,
Yeah.
they'll often come to you and say, I'm having symptoms of palpitations. And then what do you do in terms of next steps?
Yeah.
So I think you sort of have to say to them, are you getting chest pain? Are you feeling breathless? Are you feeling lightheaded? You can check their blood pressure. I don't know if you have access to doing an ECG.
Yeah, we have an access for ECG.
Yeah, so I don't know what the system for that would be, but if you have relatively easy access, you could perform an ECG if that's relatively easy to do. But I wouldn't necessarily get into that situation of performing an ECG on everybody that comes to you with palpitations. You'll have all the orthopedic surgeons down there wanting an ECG from you if you do. So I think you just ask them if they've got any sort of associated features of chest pain, dizziness, breathlessness. You can check their blood pressure and you can feel their pulse. Feeling their pulse is enough. And then I think you just have to say if your symptoms are getting worse or if you're concerned, you'd have to go to A&E. I wouldn't put yourself out more than that. I think that's more than comprehensive.
Yeah.
Obviously, if the patient's saying I'm getting palpitations and they're grey and sweaty and they've got no blood pressure and they've got chest pain, then you have to take them round to A&E to be assessed. But I wouldn't in your facility do much more than checking their pulse, checking their blood pressure, and just making sure they haven't got any of those really concerning features. And then safety netting them by saying, if your symptoms are getting worse or you're feeling more unwell, you must go to A&E. Yeah.
How reliable are the wearables like an Apple Watch? All pretty good.
I think they're pretty good. They're all a single lead ECG rather than a 12 lead. So, if you get a broad complex tachycardia, you can't differentiate a right ventricular outflow tract tachycardia from a LV apical tachycardia due to scar. You can't get that level necessarily. But in terms of is it silent, is it AF, I think they're pretty reasonable, provided you haven't got a reading with lots of artifacts, which I think it is still quite common to have artifacts getting in the way.
So it's mainly grey air. for other.
Yeah. Well, but for the SVT, it can tell you it's an SVT,
Yeah.
but that's kind of about it. It can't help you. You know, the electrophysiologist
Yeah.
will want that 12 lead
But
to
also
really.
screening, it's good.
Yeah,
It's
the
really-
screening it is
yeah.
good. It is good, and I think it has helped. One of the difficulties we then have is how much AF is enough AF to give you a left atrial appendage thrombus. So you know, with the wearables, patients are picking up very short runs of AF, and I get this a lot from colleagues. You know, can say, oh, I've had 10 seconds of AF. You know, do I need to go on a DOAC? And probably not. But so we do get quite a bit of noise potentially from them. The alive core, I think, are difficult because I don't know if you all hear when we were saying that it has to be connected to your app you have to connect it to your app on your phone. You have to get the little device out, hold it. Now, the alive core then did bring out a 6-lead ECG, but you then have to have 3 points of contact. So you've got to have your knee, a bare knee or a bare ankle. But even more difficult if you're, walking around the high street, you get your palpitations and you have to roll up your trouser leg, and it's just not practically possible. But for single lead ECG is good for saying, is it sinus? Is it an ectopic? Is it AF? Is it an SVT? It's good enough for all of those. And then the more nuanced, you ideally need more than the single lead.
Are you finding a lot of patients are bringing kind of data to you with that at the moment?
Yeah, and I think it can be helpful to be able to say that you've made now 50 recordings which you sent me, and I can reassure you that they all show sinus rhythm with occasional ectopics. So it can be helpful, but you can get volume and data overload from it. And then you can get patients who are very obsessed with sort of watching their heart rate all the time or checking their blood pressure all the time, and you've just got to make sure you're not sort of feeding healthcare anxiety, I suppose. So letting them know that they're a useful tool. I think a lot of the other thing is that a lot of the devices now will have inbuilt alarms. So, for a young fit person, having a heart rate during sleep that goes down to 35 beats per minute is actually normal. But the watch will tell them it's severely abnormal and they need to be seen. So some of the thresholds are not, they should, probably the company should be a bit more age and physical fitness aware in terms of setting their normal parameters, but they haven't done. We just sort of set a normal parameter for everybody, which doesn't take into account the person's own physiology. Really.
Where and when do you do your investigations? So this man has a murmur with someone to you. Where are you going to do the echo? Where do you do the echoes? Where do you do angiograms? Who do you get them to do them?
So I don't do, I'm a non-invasive cardiologist,
Right.
but I do all forms of imaging. So echo, CT, MR, and nuclear.
Are you going to do that here?
Well, hopefully, yeah, I'd like to.
How do you do that? You haven't found that out yet.
Well, we've had preliminary discussions, and it might involve forging new capacity, which might mean evenings and weekends, etc. So, because you're already very well served, which is a good position to be in from a referrer point of view. So, but we're usually very quick with getting appointments for echo and monitor. And for me, the most important thing is the patient will not leave the department without having a mutually agreed date for their investigations. To me, that's a real hallmark of a good quality service.
Where are you going to send your angiogram?
To colleagues within the Wellington. So a lot of my Royal Free colleagues work here. So, and before moving to London, I was consultant in Peterborough for 9 years and actually had a lot of referrals still into London. So over the last 10 years, I've developed some good links with a lot of the interventionists and cardiothoracic surgeons, who a lot of them are also working at Wellington. So I've got a reasonable understanding about who's good for what kind of patient, both in terms of their pathology, but in terms of their individual sort of needs. So things like minimally invasive mitrals, or the who's good for aortas. I do have a bit of knowledge that I've brought with me to London about the local group. We do stress echoes is the other thing that we are I'm involved in, and again, most patients will get a date within a week for a stress echo.
Yes, they do a lot of those in Wellington North. think a lot of the patients want the answers. By the time we send them to you, they need an angiogram. They're all pretty demanding, difficult.
Yeah,
Worse than that, they come from somewhere else and they're going home.
yeah.
And they're only here for X days. I'm just telling you how it is.
Yeah, I've had experience of that in another centre I work in London, and I think as a practitioner, I can be quite understanding of that and the time frame that people are on. So again, I'm developing working relationship within the Wellington and the cardiac investigations team, and I think we've got flexibility on both sides. So I think I could say with confidence that we would endeavour always to provide investigation slots in a timely manner, particularly to consider each patient's need. Obviously, we won't be able to please everybody, but
I had a patient with very small ASD that caused palpitations that wasn't picked up till a lot later. Is that through bubble echo?
yeah, often.
And so he was here and it was sort of missed. It was found when he was knitting. Is that something you do routine? At what point would you consider doing that? But when you've done excluded everything else?
So usually if the atria are normal size and they haven't commented on the intra-atrial septum being aneurysmal, and the definition of aneurysmal is a deviation of more than a centimetre from the central line, then your likelihood of having a PFO or an ASD is very low. A lot of ASDs will be associated with another congenital abnormality like a partial anomalous pulmonary venous drainage or something of that like. So you'll see dilatation of the right atrium. So there'll be something, but if both atria are completely normal and your intra-atrial septum is not dilated and they can't see colour flow, I would say that's enough to say that there is no hemodynamically significant ASD. What you often will find, and I wonder if you do go back to that patient, you'll see that the intra-atrial septum is aneurysmal.
Right.
And I think if you've got something like that, you've got an aneurysm in intra-atrial septum, then you might consider actually we want to bubble just to be completely sure.
I mean, it may have been a congenital thing that was incidental and he was just getting, because it was related to caffeine as well. So.
Yeah. I mean,
He probably had it all his life.
He will have, he will have had it all his life. He will. But there was a trend, probably like 15 or maybe more, maybe 20 years ago, about closing all PFOs and ASDs. I don't know if you remember. There was a real trend to try and close everything, and there was studies that suggested it was better for migraine sufferers, and then actually it sort of petered out. So like with a lot of these things, it kind of goes in fashion and back out of fashion again.
Actually, that's quite funny you say that, because he was getting migraines and they corrected it
and it did help. Yeah. Anecdotally, there's a lot of patients who report that, but I think on the bigger studies, they proved they couldn't get as much statistical significance.
Are you going to do your own echoes?
Yes.
I've got something dedicated to do them.
Well, I've worked with some of the cardiac physiologists here. I've worked with in NHS setting as well, so I've got a good working relationship with them. And I throughout my career, I have always tried to support and develop the role of the cardiac physiologist. So brought in strategies to give them a lot more autonomy and ownership of their reporting and more physiology delivered services and things. And the same thing with radiographers who I've worked with over the years. I am pro developing allied healthcare professionals.
The only reason is that somebody comes to see you, you've got an appointment. Your appointment's half an hour, say.
Yes, no, they're half an hour.
Right.
Yeah.
So, and then you go, I need an echo.
Yeah.
If you had the echo machine in outpatient,
There and there.
what do you think of that? Rubbish?
No, not rubbish at all. I mean, another project I'm working on is the use of the handheld echo with AI, and we're actually working with a group of GPs in North Central London to actually roll that out into primary care, because there's always this sort of discussion point around the use of echo, and the BSc have very strict criteria about what constitutes an echo, and the BSc, as well as writing national standards, so a union body of physiologists, so it has many different roles. But I think there's, if you are seeing a patient in clinic and you can examine them and you can look at their ECG and their chest X-ray, and you could do a handheld echo using AI and put it all to bed, then isn't that a brilliant solution rather than having to say, right, we've now got to send you for another test, that's going to take an hour. The place that you can get it is, 3 buses away. And
Yeah, well, you've said you've already brought in AI now. So here you are sitting in your consulting room, you've got your ECG, you get a chest X-ray downstairs just like that.
yeah,
Can't get one on your floor or whichever floor you're on unless you send them downstairs. Then you want to do the echo. So you need an echo built into where you are. In the north, I don't know. I don't think the cardiologist there have an echo. Is there a cardiologist over there who does
Yes,
echo?
there is
Who is it?
in North.
Who?
Usually there is mostly are the consultant, there are cardiologists, and they will order, but usually the
That's why
setting,
I asked you. Who does it?
there is a technician who do the cardio, but it's not instantly. They will be scheduled.
Are you asking which cardiologists do the echoes?
Yes.
It's a technician.
You see, there was a guy called Duar who did them in.
just
Yeah.
yeah.
Now, he used to do them in, still does them in St John and Elizabeth.
Yeah,
But what I'm asking any of you, if you know, we know Littman's there, and we know, all of them are there. But I don't believe any of them do echoes there and then on the patient. Or do they?
It needs to be booked.
No, it needs to be booked.
Yeah, not
So they go
immediately.
and see, you're learning now. so-
no. I'm aware of this because it has to be a full protocol echo, and you couldn't in the course of a clinic list, stop and do a 45-minute echo for the patient that you've just seen because you've got 3 or 4 more waiting for you to do a clinical consult.
There are cardiologists who do that.
And they get reimbursed? Because that would be
I won't tell you who they are. They're already earning a fortune anyway.
Oh,
They have longer, they probably have double slots.
They do. I mean, and also the cardiologist at Cleveland,
Mhm.
the boss, works from 5 in the morning till 12 at night,
Oh my goodness.
every day of the week, 7 days.
Oh my goodness.
Don't worry, he gets paid. Look, a lot of money.
George,
So George went over there and he's so busy
Mhm.
because he speaks lots of languages. So he sees more patients than all the others put together squared. He's also head of King's.
Wow.
But basically, he does his own echoes.
Mhm.
So he'll see you and he'll go, you've got aortic stenosis, go down there. And he's got about 5 rooms and runs them all.
Yes.
Now, that's a different way of medicine. I don't know anybody else do you who
They do it at 78 College Street.
they do it 7800. But who's doing it?
Sultan,
So
Gajan Sultan Kanaganayakam.
Dr. K.
He does it. There are a few other people.
Not pronounced,
Otherwise,
spell
he
his
gets-
surname.
And
we're saying this because you can see there are cardiologists who do that.
they do it then and there.
There and there, yeah, exactly.
But it's probably
Okay.
predictive. They've got a double appointment.
Yes, oh yes.
So
That's why I asked you how long your consultants are.
Yeah.
You see what I mean? It depends on your practice, really, and what you're going to do.
Mhm.
And I'm sure that'll be shaped. And
I
that's
suppose you could vet the letter and then do a double appointment.
You-
I think they
and-
definitely.
yeah. I think if I'd examined a patient and I felt there was something clinically very relevant, I would not let them leave without having an echo. We'd engineer getting one somehow. Yeah, hopefully things will evolve and change depending on what patients and what referrers want.
I mean, or otherwise they're just doing a screening, very brief echo, just to do the very basics and then send them for a more detailed study.
I'm sure that a lot of them have dedicated cardiac nurses who do the echoes for them, as Tim says.
Mm.
So, and then they go, and if they find anything, then it's looked at again.
Yes, yes.
But I mean, it depends on how you're going to run your practice. That's why I was just interested. It's the same for angiograms.
Yes.
You see, somebody comes down from, I don't know, anywhere north of Watford and
Yes.
says, I want an angiogram, Peterborough.
Yes.
And they don't want to go all the way back to Peterborough.
No,
without-
we don't, without having it done.
It's
Yeah.
quite a lot to organise.
It is. There are a lot of diagnostics can often, because your capacity for cardiac CT is 5 days a week, isn't it? 5 days a week for cardiac CT and to cardiac MR.
Is it? Then we go into weekends, and that's different. And then different people don't want to work at weekends, and different people do.
Mm.
This place is not open at weekends.
that is a discussion that we are actually having with Dr. Schofield.
So I'm not averse to a weekend.
But you know, if you live in Scotland, you don't want to be here at weekends. Do you see what I mean?
I do.
Does anybody online have any other questions?
Oh, 45 patient with palpitations. So in a patient 45 years with palpitations and possible colour flow across the intratracheal septum on transthoracic echo, is this normal or is it a PFO? Everything else is normal. Cardiologist wrote back saying everything's normal. So if there is query colour flow, then on the transthoracic alone, they haven't ruled out a PFO or a small ASD. Then the next question is it clinically relevant? And you could argue that given the patient is symptomatic with palpitations, it may be clinically relevant. And so you want to have you want to use a bubble echo to then confirm or refute the fact that they do or they don't have a PFO or an ASD. So the cardiologist may have written back saying everything was normal, but you could argue that in the context of palpitation and possible colour flow, does the patient warrant a bubble echo to be clear as to whether or not there is a PFO or ASD? But you wouldn't necessarily close a PFO or ASD in the UK based on palpitations alone. But as we said, the risk of them developing atrial arrhythmia is much higher than in a patient who does not have a PFO or an ASD. So in terms of counselling the patient, I think it is important to know one way or the other as to whether or not there is or there isn't. That would be my opinion. Yeah, so the issue with the PFOs and the ASDs in this country became then the commissioning and the different centres that were commissioned. So that has influenced practice. So thromboembolic complications, so a TIA, a stroke, is an absolute indication to close it. Migraine was, but isn't anymore. And less and less centres are doing that work nationally. Within London, there's still a lot of ASD closure that is happening. So I don't know if that's helped at all, my answers to your questions. But I think I would be tempted to go back and say, you know, in the context of palpitation, isn't it important that we do a bubble echo to be sure if there is or there isn't intra-atrial communication, such as a PFO or small ASD, both in terms of counselling the patient now, but also counselling in terms of their potential for longer term sequelae, and to allow them the opportunity to discuss the merits and disadvantages of closure. Yeah, you can do bubble echoes on the NHS. But it usually will be a consultant cardiologist or sometimes stroke physician or neurologist are allowed to request. Pleasure.
Thank you, everybody, for joining online. You can reach out to Dr. Schofield, your email address. I can share that afterwards, your private practice email address. Thank you for joining.
Thank you.
Thank you.
Thanks a lot. Bye.
Thanks, Alec.
Bye.